The techniques you've learned before are good ones. So, you know, a glide is a perfectly fine way of mobilizing for ankle dorsiflexion. But what I would say is speed up your treatment, speed up the success rate, you know, for yourself by just being more specific. So sometimes the whole thing might be limited, but it may not be entirely limited. Find out, is it medial, in the middle, or lateral? You'll have more glide on the lateral side of the medial because of the shape of the bone, so that would be normal. If one part is restricted or painful, then that's probably the part that needs to be mobilized. So you can do it just in the ways that you have, and then if you're going to do it on the lateral side, because it'll glide so much further down, you'll end up getting more eversion. Consider doing it with the legs apart, because when you're walking and you need the most dorsiflexion, your foot's behind you in abduction, so it puts a little bit different spin on the soft tissues, and you might gain something there. So that's here it is. So that is number 3. Would you get up and tall, Neely? So another way to do it, you could actually want to do it standing up. Oh no, let's go down here, because after our little experiment with it, go over there. So those of you who haven't done a Mulligan mob, this is a way that you would do it. You can use your web space across the front of the ankle. I usually show it on the other leg first, so the patient knows what to expect. And just see if you glide your knee directly at and this is perhaps what you've done in lab. But what I like to do is to be a little bit more specific, find out, what part of the ankle isn't that's restricting the movement. So let's just try, and on the lateral malleolus, the most distal part, you're going to hold that part back. And which direction should it go? Posterior. Posterior. So as he goes forward, move your shoulder, knee to your shoulder, it should go backwards. And it would look the same thing as if we did on the medial side. On the medial side, come forward, and his also goes back, and his also doesn't hurt. We'll find somebody in this class where you do this in the desert, and when that happens, you have to condition them to what it's going to feel like. And then you go ahead and say, I know it hurts, but it's not supposed to hurt that way. As you after you've done it a few times, it'll start feeling better. So just go lunge your knee right at me, and you just hold your ground. You could even stabilize your thumb with your other hand and go back until that malleolus starts going posterior. Once it does, that'll be the same time that it no longer hurts. You could do it for the talus as well. If both malleolus are moving fine, come forward, then we could see, the talus is not moving, and you can just localize on that spot. It's not usually all 3. So you just speed up your process by just going to the one part that's limited. And don't waste time. Okay. What's in mind? Number 5 is a thrust for the proximal tib fib. This relates to your ankle dorsiflexion, because if the distal end of the fibula should go backwards in dorsiflexion, the proximal side would go forwards, right? So if that is restricted, then you would need to mobilize that as well. So in order to do that, we start out in hook line. You find the fibular head by putting your hand behind his leg, moving the soft tissues of his gastroconcilius out of the way, and that'll leave the back of the fibular head resting right on my phalange. All right? Check to see he has full range of motion. You're good? He has full knee range of motion, so I'm not going to hurt him. Okay. So I'm here. I pull this soft tissue out of the way. I take up the slack so he can feel, so I can feel his fibular head right there on my finger. Then I take his leg and I'm going to externally rotate it, and that will bring the fibular head right up against my finger. The mobilizing force is going to be my right arm straight back in the direction of my forearm, right back at his buttock. All right. So I'm here. Take a few. Practice goes. And all the way to full range. I know I'm not going to hurt it because I tested ahead of time. All right. So I'm not going to hurt it. So one more time. I'll do it on this side so you can see. Take up the soft tissues, gastrocsoleus, push his fibular head against my phalange, lock it in by externally rotating the fibula, take him to the end range, hang up. Okay, so those are all for dorsal. Slide forward a little bit. That's a little bit further. For plantar flexion in the other direction, you can also start in hook lying, and obviously it's the other direction. We want the talus to come all the way out of the malleolus, the mortise, as much as possible. So in order to make sure that that happens, I want to really stabilize this proximal tibia and fibula. So as distal as I can go, I'm going to lock it up, and then I'm going to use my elbow on my hip, so really this does not move. And now I'll take my hand below it and mobilize the talus down. So that looks like this. I'm going to take the talus, pull it out and down. But I don't want the tibia and fibula to move. So I locked it up, hold it down. It's not a very exciting motion, nothing, no crackling. It's just pull it all the way. You good? And slide it back. Well, see, the question was how many times? And I'll say the goal is the outcome. So if it took me one time to do it, and I got the outcome, that's as many times as I need to do it. If it takes me 10 times, I'll start wondering whether it's really the right outcome. All right, and then the technique for the subtalar joint supination, I think it's the only one that I listed there, can be done like this. This is a mobilization with movement. I'll do it on both sides. So you take the lateral malleolus and you put it right in the crux of your hypothenar and thenar eminence and hold it there. You should know you're in the right position and pushing in the right direction if your foot moves back and forth like that. Because it's not straight down, as you might have learned in a worker course, and it's not straight up, it's back and up. All right? So from that position, it could just be done actively. Turn your foot into the other side, all the way. Keep going. So you take it to the end range. You could do it actively, or you could do it passively. Take it out to the range, and then take your foot and press it over further. You can do this for someone who has an ankle sprain. Not acute. They might have pain on this outside, and so they'll have pain during this motion. If you hold this down and you move it out like that and it's painless as it's supposed to be, for a person with a chronic ankle sprain, then that would make you wonder whether it was really the ankle sprain that was causing pain, right? That would clearly be a stretch in the ATF. So many people who have chronic ankle sprain have pain in this region, but not necessarily because the ATF didn't heal. Past 8 weeks, it's probably healed up. So you can do this motion because that is something that they will lack and it's helpful. And sometimes the reason is that the fibular head, fibula malleoli, has been yanked forward and stayed forward, and that's what's causing that pain, not necessarily the ATF itself. Okay, break it up. Let's try this out.